The next case will be a woman. The systematic QS examination show a cystic lesion of the body of the pancreas. The patient was asymptomatic. The MRI show two cystic lesions, one of 10 millimeters in the isthmus and one of 20 millimeters at the junction body tail. So the operators, Dr. Saf Tuyu, Dr. Cheng, will perform US and confocal endomicroscopy with fluid aspiration. And I will show you the MRI, the two lesions, one in the isthmus and one in the tail of pancreas.
Okay, so now you see the big lesion. So we are in this with the scope in the stomach, and we look towards the pancreatic body and tail. So you can easily see the vascular elements. So now you see the splenic artery and the splenic vein, and you see the lesion here. So it's towards the tail of the pancreas, and it's we think this is the biggest lesion. So it's we measured it already, but let me see if I can get again the HiCom and Doppler, the tissue harmonic imaging, sorry. So now you can appreciate maybe better the characteristics of the lesion, which is very close to the splenic artery.
Just move a little bit.
Yeah,
yeah.
Maybe here.
It's hard to stay there, isn't it?
Yeah, it's difficult on the... Could you help a bit with the torquing of the scope?
Well, yeah, can you get gloves?
Okay, no, I think I'm in. Okay. So now we'll try, I think we are in. Yeah. So now we'll try to advance the confocal fiber. It's okay, I'm fine, maybe. We'll try to advance a bit the confocal fiber. Okay. So now you see, I don't know if you can see that on the... So this is the needle tip somewhere here, and the confocal is a bit more far away. So now we can try to manipulate a bit the needle towards the wall. So I'm not sure if the image is as good as in the other case, as it's a small lesion. So maybe here. So now you see similar structures with the previous case. So again, yeah, again it's vascular structures. Yeah, vascular. Yeah. So this also might be. We already mark here, but it's a serous cystadenoma probably. Yeah.
We found this in 72% of cases. The sensitivity of this sign is very high, and specificity is very high. Sensibility is around 70%.
Yeah, so we'll try to find a better place. So what we can do, we can target various parts, but it's really difficult to stabilize the scope in the stomach. So, okay, maybe here, if I withdraw a bit. Yeah, now it's pretty far. Okay, maybe now.
There we go.
Yeah. Now it's probably now it's in the pancreatic tissue. So I think I slipped a bit, and now it might be on the pancreatic tissue. I'm not sure if I'm in the cyst anymore.
Yeah, these clumps are maybe pancreatic parenchyma.
Yeah, exactly. Yeah. It slipped a bit in the pancreatic, but we can withdraw the fiber then. Yeah, that's some erythrocytes in fluorescein now. So we can withdraw, and do you think we need to aspirate? I think we can leave it like this. So I think it looks like a serous cystadenoma. Of course we can aspirate the lesion. So let me just withdraw the needle. Okay.
So you want to retarget it?
Yeah, just trying to get it out. Yeah, completely. Okay.
So take the probe out.
Yeah, it's out.
Do you want to style that?
I'm not sure. What's the opinion in the audience? Should we FNA this one or should we stop right now? I mean, it's a 2 centimeter lesion which looks, which looks like a zero cystadenoma. So.
If we have a CA level very low,
Okay.
we'll be happy. And now the needle is inside, and you can aspirate a little bit fluid, will be okay.
Yeah, it's really small, and that's the splenic artery nearby. So.
You still see that?
For me,
You
for
still-
me it's enough, man.
We can do it with an FNA, so it's not a problem. But the question is, should we do FNA? I mean, do we still need that? Would you do that? Or
Do you still get the
we
component
can-
that comes up?
I think.
Where's that
yeah.
component that comes closer?
Yeah, actually, I think it decreased a bit in size. Probably we aspirated a bit when we withdraw the needle. So now it's really small.
Do you want to use a smaller needle since this is less likely mucinous, or?
Yeah, but I wouldn't do too much. I mean,
Okay.
does it make sense to aspirate? We know it might be a serous cystadenoma, and it's
Right.
only 20 millimeters, so it's borderline in an asymptomatic patient. So I would leave it like this without an FNA.